Well, good morning. Well, the morning after a city sports championship is always a lot of fun. So I see some red, and we have a couple of props here. Yes. So congratulations, go Caps, to the city. I'm Anand Parikh. I'm the Chief Medical Advisor here at the Bipartisan Policy Center. I want to welcome all of you to today's event entitled Healthy Homes Equal Healthier Lives. For those of you who are new to BPC, our mission is to actively seek to combine the best ideas from both political parties to promote health, security, and opportunity for all Americans. We drive principled and politically viable policy solutions through the power of analysis, negotiation, and advocacy. On Monday, BPC released a report highlighting the importance of more tightly linking federal health and housing policies to improve health status and quality of life for vulnerable Americans, while more efficiently and effectively allocating limited resources. BPC's report makes specific recommendations for HUD and Health and Human Services, HHS, on how to better collaborate on issues ranging from healthy homes to healthy aging to behavioral health and disaster preparedness and recovery. Simply speaking, we spend more time in our home setting than anywhere else. If we want to improve health, look no further than the home. Whether it's safer homes to prevent falls, or to reduce lead exposure and asthma triggers, or whether it's bringing health services into the home, into the congregate settings, or through telehealth, health housing integration is the future. And for those without a home, homeless, or at risk for homelessness, or low-income renters, these are the most vulnerable and deserve our attention. That's what makes affordable housing policy so important in this country. BPC's current efforts build on previous work led by BPC's Senior Health and Housing Task Force, co-chaired by former HUD Secretaries Henry Cisneros and Mel Martinez, and former members of Congress Allison Schwartz and Vin Weber, as well as builds on previous efforts of BPC's Housing Commission, led by the two secretaries, along with former Senator Kit Bond and former Senate Majority Leader and BPC co-founder George Mitchell. Today we are honored to be joined by HUD Secretary Dr. Ben Carson, who will be coming on stage in a moment with BPC President Jason Grimet. Following a discussion with Secretary Carson, we'll have a panel discussion with healthcare and housing leaders on how to accelerate health housing integration in the public and private sectors. As a reminder, this event is being streamed live online, and a recording will be available next week. We invite you to interact with us on Twitter about today's event using hashtag BPC Live and the handle BPC_bipartisan. We'll be taking questions today after both of our discussion panels. If you have questions after the first panel, we have note cards available. Please write down your questions on the card, and you can do this as the discussion is ongoing, and someone will be around to collect them. So at this time, I'd like to introduce Dr. Ben Carson, who is the 17th Secretary of the U.S. Department of Housing and Urban Development. Prior to serving in the administration for nearly 30 years, Secretary Carson served as Director of Pediatric Neurosurgery at the Johns Hopkins Children's Center. Dr. Carson has received dozens of honors and awards in recognition of his achievements, including the Presidential Medal of Freedom, the nation's highest civilian honor. Dr. Carson has authored 9 books, 4 of which he co-wrote with his wife, Candy. He and his wife have also co-founded the Carson Scholars Fund, which recognizes young people of all backgrounds for exceptional academic and humanitarian accomplishments. Born in Detroit to a single mother with a 3rd grade education who worked multiple jobs to support their family, Secretary Carson was raised to love reading and education. He and his wife are the proud parents of 3 adult sons and 3 grandchildren. And Mr. Secretary, as someone also born in Detroit, also a graduate of the University of Michigan Medical School, and also a faculty member at Johns Hopkins Hospital, so nice to welcome you to BPC. So at this time, please welcome HUD Secretary Dr. Ben Carson and BPC President Jason Grimet to the stage.
Well, good morning, everyone. I see some very happy and a couple of tired-looking folks in the crowd today. We have our towels up here in case anything spills. It's a real honor, Secretary, to be with you here at the Bipartisan Policy Center as Anand says housing and the fundamental role that housing plays in economic growth and education and mental health has really been core to a lot of our work over the years. And my first question to you is, as Dr. Carson, you are the 17th Secretary of HUD, but the first person with the medical history to lead this agency. And I just wonder if you could just broadly, how does your worldview as a physician influence your imagination of the role of the Secretary of the Housing Department?
Well, first of all, delighted to be here. My Deputy Secretary, Pam Petnote, sends her regards.
We miss Pam.
And, I had a conversation last week with Megan Sandell from the Boston Medical Center regarding this whole topic. And it's obviously something that's very important to me. As a pediatric neurosurgeon, I spent a lot of time working very hard on little kids, sometimes operating all night long, trying to give them a second chance at life. And most of the times we were successful. But then I found myself in a terrible dilemma, because a few days later they're ready to go home. And many of those homes were pretty awful places. I mean, rats and roaches and bed bugs and mold and lead and crime, and you just say, how in the world can you in good conscience send somebody back into an environment like that? Well, now there's an actual opportunity to try to fix that. And I feel very, very passionate about the need to recognize that your home is the foundation of your security. And you'll notice when, a squirrel, you go up to a squirrel, what do? They run back to their hole. Any place, that is your security. And we have to recognize that as a society and begin to think about, how do we provide a holistic, nurturing environment for our people? The people who don't have that, and the poor, the disabled, the elderly, those are the people who are at greatest risk of health problems related to insecure housing. So it's a perfect nexus for us to be working with HHS and with multiple other agencies in order to see what we can do to provide safe housing and affordable housing for our populace.
So let's talk a little more about the partnership with HHS. Their budget's slightly larger than HUD's by a factor of about 20. And there's been a big conversation in this country about the need to focus on healthcare, not sick care, and the social determinants of health. And as you just alluded to, housing as really that foundation. Can you talk a little bit about some of the programs and some of the collaboration? How do you and the Secretary of HHS get together?
Oh yes, absolutely.
How does that work?
It works actually very well. We talk about some of the things, obviously dealing with lead, for instance, because you hear about lead and you think you know something about it, but the fact of the matter is, for children under the age of 6, lead exposure can have a devastating impact on the development of the brain. And not just a short-term impact, but a very long-term impact, which can affect the way that person thinks and behaves throughout their entire life, greatly decreasing, their potential. And that costs us as a society, not only monetarily, and it can be hundreds of thousands of dollars for a single individual, but also in terms of lost potential.
Sure.
And we have to recognize that our people are our biggest resource. And really, that's where we should be aiming our policies. Looking at prevention is another thing that we've been talking about, because it costs a lot less if we can prevent the thing than it does when we're trying to treat it. So when you're looking at something like asthma, and you're looking at poor ventilation, you're looking at rats and roaches and other types of pests and the kinds of things that they bring into the environment. You look at the mold, and you look at the impact on our society, on our HHS budget for asthma. You're talking multiple billions of dollars every single year. So when we're talking about remediating these kinds of things and programs to remediate them, that's going to be a great benefit to our entire society. Also, we're talking about data sharing, because we have a lot of data that's accumulated through the programs. HHS has a lot of data, and when we learn how to overlay that data in order to identify the areas that are most in need of services, and to target the areas where we should concentrate our efforts. Not that we would neglect any effort, but we need to be able to target to get the biggest bang for the buck.
Well, I was sharing with the Secretary earlier that we here at the Bipartisan Policy Center also have a quaint affinity for data and evidence, and we find that there's a great amount of work to do to gather the evidence, and then we often stop. And the fact that you actually want to use the evidence in a way that is going to be publicly accessible, something I want to talk about a little bit.
Well, interestingly enough, if you look at longevity in this country, and you go back to the previous turn of the century, not the one at 2000, but the one before that, the average age of death was in the 50s. At the last turn of the century, we're approaching 80. Now, how did that happen? Was there some kind of miraculous improvement in our genetic structure? I don't think so. What happened is that the medical profession began to use evidence instead of ideology in terms of the policies for our health, and what a difference it has made.
So, Mr. Secretary, you talked about lead and asthma, which I think have been long understood to be kind of chronic health issues affecting families. We're focused a lot right now, and I know you are too, on the opioid epidemic, which, as I think about it, is really the crucible of almost everything that's not working right now in American society. And it is, like so many kind of chronic issues, focused on people who don't have the resources and the access to care. Where are you on this? What is HUD's role going to be in battling this crisis? Is this an opportunity for you as a physician to really lead the administration?
Well, as you know, the President declared the opioid epidemic a national health emergency. And it really is, and it affects every level of our society, from the lowest economic rung to the highest economic rung. We have drugs coming in, from our southern border. Now we have drugs coming in through the mail. A lot of comes in through the water. Last week was the installation of the new commander of the Coast Guard. And they were talking about how much drugs are being interdicted by the Coast Guard. I mean, by the boatload, no pun intended, is coming in. And it's actually the largest area of our government that is actually able to intercept these things. But here's what we need to be thinking about: the holistic treatment of people with opioid addiction. And we have a lot of programs all over the country aimed at this, but a lot of them are not adequately funded and don't really take into account the fact that opioids actually change the brain. Now, people think you get addicted to opioids because you get an injury and the doctor gives you these medications. That's all true. But what most people don't know is that opioids are terrible when it comes to pain relief. They're not the best pain relief at all. And in fact, someone who is able to accurately describe things for you, you give them opioids for pain and then ask them, how's their pain? And they'll say, it's still there, I just don't care. Because that's what it does, it makes you not care about the pain. And it doesn't matter what kind of pain it is. It can be emotional pain as well. And that's exactly, I think, the reason that we're having such an epidemic. There's so many people in our society who have lost hope, who are thinking, I can't make it. The system is stacked against me. Those people hate me. I'm just going to go over here and sit in my corner. If I can get some kind of relief from that for an hour or two or a day, I'm going to take it. Mm-hmm. We need to be thinking, and this is a departure from what a lot of people think, but we need to be thinking about how do we create the right kind of nurturing environment for our people so that they don't feel like it's hopeless. That's one of the reasons that, we started the Envision.
Yeah, I was going to ask, so yesterday in Detroit, you announced the first of what I think will be 17 of these Envision centers. And
17 in the first cohort.
Right, so hot off the presses, Mr. Secretary. I'm guessing that everyone here does not yet know the imagination and the kind of goals of the Envision centers. Why don't you give us a few minutes on that?
Well, it actually was inspired by a verse in the book of Proverbs, Proverbs 29:18. It says, without a vision, the people perish. And that is absolutely true. You have to have that vision. It was Helen Keller who said, I would rather be without sight than without vision. And, when people don't think that there's hope and they can't see that American dream for them, they give up. Well, Envision centers actually bring the resources of our government, federal, state, local, as well as nonprofits, faith-based communities, private sector, all together under a single roof, along with the need. The system, the way it exists now, is so complex, I don't think Einstein could work his way through them, quite frankly. But we're fixing it so that people can actually get the kind of services that they need. So that that young mother whose education ended with that first baby now can be directed to the appropriate place for her child care so she can get her GED, her bachelor's degree, become self-sufficient, teach that to her children. And we're coordinating services to be able to do that. For instance, I didn't even know this myself, but the Department of Defense has a program where they will come into a multi-family dwelling and they will teach elderly residents there the fundamentals of child care to the point where they can get certification. All of a sudden, they now have the possibility of being able to take care of some of their neighbors' children while those young women go out and get their education finished and become independent. That's what I mean when I talk about amalgamating and coordinating services. Those are the kinds of things that would make a difference, making it possible for mentoring to occur for people. Many studies have shown that young people, particularly disadvantaged, who are mentored, finish high school at a much higher rate than those who do not. And also, when it comes to data and poverty, look at some of the data that was accumulated by some of the foundations that have been looking at poverty. And discovered that there are 3 factors that reduce your risk of living in poverty to 2% or less. Number 1, finish high school. Number 2, get married. Number 3, wait until you're married to have children. Those 3 things, less than 2% chance of living in poverty. That's big news. And we should be thinking about that. And that's one of the reasons that, we're looking at ways to reevaluate rent structures so that they don't discourage marriage. Right now, if your income goes up, regardless of what the cause is, like bringing in another source of income, your rent goes way up, or you lose your eligibility all of a sudden. And that's why when we go into a lot of these places, like I was in a place recently with 700 units, 99% of them occupied by single women with children. And I'm sure that if we provide the right kinds of circumstances, we're not going to have a continuation of that. But we have to change that policy so that we don't punish people when they begin to climb the ladder, when they begin to get increased income, when they, get married, things like that. And I don't think we did it intentionally, but it's where we ended up. And we have to deal with where we are now.
So I think that, we should talk a little about the incentives around HUD support for the poorest folks in these situations, because I think there's a strong sense that some of these incentives are really disincentives to progress.
They're perverse.
But there has been a lot of confusion in the last couple months about the proposal that came out in late April, which was, kind of simplistically described as, we're just trying to triple the rents on impoverished people.
I'm glad you brought that up.
I knew you would be. And again, you made some statements about this yesterday, which I want to give you a chance to really build upon, but there was concern that this essentially could take, 1 million vulnerable kids and put them on that borderline between having a house, even not a great one, and having no house. And I know you know better than anybody in this room, it's hard to lift people up when they're on the streets.
Exactly.
What was going on in the proposal? Because my understanding is now that you've found some more resources, but just take us back to April, and what was the imagination behind that proposal?
It's always good to ask questions like that, because if you filter things through the media, you get a very distorted view. For instance, just as an example, small market, fair market rents. They said Carson's against that. He's against people being able to move into areas of opportunity. What a bunch of crap. There were a bunch of places that said, we're not ready to switch over yet. So what we said is that if you're ready to switch over, you can switch over immediately. And if you're not, we're going to give you more time. The media reinterprets that as something else. But, with the rent structure, what we're trying to do is actually create the right environment to get people out of poverty. Now, in terms of the rent increases, the tripling of rent, that was for people who pay the minimum rent. $50 a month is the minimum rent. And we propose raising that to $150. Very few people who actually are receiving housing assistance pay the minimum rent. So, that was really blown way out of proportion. But the reason we had to consider raising rents at all is because we were dealing with a $41 billion budget. And in order to be able to keep from raising rents on the elderly and the disabled, and in order to not displace people who were already being taken care of, that was necessary. Now that the budget has been changed, the necessity for doing that is not urgent. So now I say we will do what is necessary based on the budget that we have. But that was the reason, and I don't think that reason is quite as urgent now. So in our negotiations with Congress, obviously there will be a fair amount of latitude in that particular area. But the parts of the rent reform that the media doesn't talk about are the important parts. And that is giving local control to PHAs and landlords to be able to enact programs that will increase the likelihood of self-sufficiency, of doing triannual, every 3-year evaluation of your income, because obviously your rent is based on your income. And that way, you don't have people turning down raises or turning down promotions because they don't want their rent to go up. Those are the kinds of things that are important. And if people were less inflammatory and actually tried to work together, I try to work together with people. They don't want to work with you. They say they do, but they don't. They just want, whatever they want. I think there is a lot of potential in our society and a lot of good ideals, and they come from both sides. And we have to stop this my way or the highway business. In medicine, one of the reasons I think we were very successful, during my time, is because we listened to people who had different ideals. And sometimes it wasn't your ideal. But when you really stopped and you talked about it and you begin to hash it out and you begin to amalgamate the ideals, all of a sudden you realize it is a good idea. And what we need to be thinking about as a society right now is that we only have 330 million people, a quarter of what China and India have, and we have to compete with them in the future. We have to develop all of our people. Our policies have to be aimed at developing our people, not aimed at, creating a group of people who are beholden to you. But, we need to be thinking about the strength of our country. And we're very open to suggestions at HUD right now. Because, it's my belief that the government works for the people. The people don't work for the government. A lot of bureaucrats don't realize that, but we realize that. And when people have good ideas and they can show that they work with evidence, with real data, believe me, you will have a very open ear.
Mr. Secretary, you have just given the Bipartisan Policy Center elevator speech with greater skill than I often do, so I'm going to make sure we get that on our website. Because, this place is about the constructive collision of ideas, right? People who fundamentally have strong, deeply seated personal views who are willing to listen to people they disagree with, and I really appreciate your presenting it in that manner. I want to come back on the Envision centers, because I think they, in my mind, and I know this is an idea you're just fleshing out, but they fill a really interesting space in this larger debate about individual responsibility and how people lift themselves up. Because I think one of the other aspects of the rent reform discussion, but it's broadly throughout the entire welfare reform discussion, is this idea of work requirements. And I think the imagination behind work requirements is opportunity. Give people a chance to have the skills and the discipline and I think the sense of achievement. And the contrary view is that they're punitive, right? That they're somehow punishments, that you're taking people who don't have childcare, don't have transportation, don't have the right attire, and you're just basically forcing them to kind of, make poverty even a little harder.
Right.
Would working in an Envision Center, would taking a GED class in an Envision Center, would getting help, would that be, in your mind, something that should be creditable towards that idea of a work requirement?
Absolutely. I mean, it's the wraparound. It's a wraparound concept. The reason the HUD VASH program works is because HUD provides the housing, and the VA provides the wraparound services. That's why there's been a dramatic drop in homelessness in veterans. Many of these people are traumatized, the veterans, and if you just give them a house, it doesn't work. And if you just give them wraparound services, it doesn't work. But when you do it together, it works. It's the same kind of thing we're talking about here. People have to be able to get the skills, right? You probably saw 2 days ago in the headlines that there are now more jobs than there are people looking for jobs. The problem is a lot of those jobs are skilled jobs. Right. And that's one of the reasons that we put this excessive emphasis now on Section 3, part of the Fair Housing Act. It says if you're getting HUD money, you have an obligation to hire, train, and give contracts to the low-income people in that area. People found all kinds of ways to skirt that. We're putting some teeth in it and some incentives to make sure that it is used, because we have the workforce. All we have to do is train them. And when you give people those marketable skills, now they're able to climb the ladder of self-sufficiency. And again, I keep using that word because it's so important to me. Growing up in an environment where there were a lot of very poor and disadvantaged people, but I did see people escape. I was one of them. Kind of recognize what's necessary to get out of there. And that's what I want to try to provide for everybody else. Those same kinds of advantages that I had, because I had a bulldog mother who just, I could tell you all day about my mother.
Those intangibles. Yeah.
Absolutely. But if everybody had a mother like mine, we wouldn't have these problems. But anyway, we do need to provide all of those things for our people, and we need to stop fighting. The thing that will destroy our nation is the horrible wedge driving. Race, income, religion, political affiliation, age, you name it. driving wedges of hatred. It's destroying our society. There have been many other societies historically that have been destroyed by it. There have been none, I guarantee you, that have been helped by it.
So one of the fights that's a good fight in a democracy is about resources and priorities. And we struggle with this all the time. We care deeply about fiscal sustainability. We work on the debt and deficit all the time. I think it is tragic that my kids have a $20 trillion check waiting for them when they enter the workforce.
26 trillion.
We are, and they're going to be disappointed to hear that.
Hold that thought for a moment, because I just want to piggyback on that. If we continue to accumulate debt at the rate that we're doing it, by the year 2048, every penny the government takes in will be used to service the debt. There will be no money for any programs. There'll be no money for the military. And there are several countries that have gone bankrupt. You know their stories. They all knew 30 years ahead of time that they were going bankrupt. What did they do? Kick the can down the road. Are we smart enough to be both compassionate and fiscally responsible?
So if you could come back with Secretary Mnuchin, I would love to have a tax policy forum at the BPC, because we now have an envelope, right, of real pressure. The amount of pressure on the federal budget, if you believe CBO and others, is now increased by about $1 trillion. And so we're very concerned about that, as I know you are too, and I read your book. And at the same time, the amount of resources in affordable housing just don't seem adequate to the task. I mean, my understanding is there's about a 7 million gap between affordable housing and need. I know you are always struggling to figure out with the resources you have how to, I mean, you just said you have to choose between providing resources for the elderly, the disabled, and the impoverished. That's not a fun choice.
No, it's not.
So how do you, as a leader of the administration and a leader of HUD, how do you reconcile that? I mean, do we have enough resources at HUD to address the imperatives that are in your mandate?
Well, no. But necessity is the mother of invention. And we're smart people. And what we have to do is we have to figure out, how do we get bang for the buck? And that means looking at the data, looking at the things that actually work. When it comes to homelessness, for instance, there's more than 7,000 different homelessness programs that we support through the continuum of care. But what we're doing now is we're looking at the ones that are actually getting people out of poverty. We're getting, there was one group in Columbus, Ohio, a transitional housing group. They were getting people off the streets, families off the street, and into permanent housing in less than 30 days. I mean, it was absolutely phenomenal. I've never seen anything like it before. And, I made the mistake of complimenting them. I said, you have nice facilities, but it's not luxurious, but you put your money where it needs to be, getting people. And there was a reporter there, and I said, Carson says poor people shouldn't live in comfort. What a bunch of crap. But, this is the society that we live in today. Everybody just trying to create problems. But what if we use that energy to try to solve problems?
So I just got handed about a dozen really good questions. I have one of my own before I start to refer to these. And that is the focus on the incredible challenge your department and the country's been facing around natural disasters. As I think everyone knows, last year, country suffered about $300 billion in disaster-related damage. Just when it comes to housing alone, I think we had about 25 million people displaced. 5 million people sought immediate kind of FEMA assistance because they were at least temporarily homeless. I know my dear friend Pam has been in Puerto Rico more than she might have imagined when she accepted this position. How's that going? I mean, can you talk a little bit about HUD's role? And then again, do you feel like does the country have a system to both be resilient to and effectively respond to these disasters?
Good question. Well, I mean, this was an unprecedented season that we just went through, so I got to be baptized in the fire. But, we have put resources on the ground before each one of the hurricanes. Before it happened, to begin identifying where we could place people and what kinds of things needed to be done, and have remained there throughout, working hand in hand with FEMA. As you know, HUD is responsible for the long-term recovering, FEMA for the short-term. But we began working together immediately, providing forbearance on people with their mortgages and moratoriums on foreclosures, providing certain types of loans and tacking the cost on at the end of the mortgage. Those are the kinds of things that are tangible that really help people, but also, dispersing the $35.4 billion several months ahead of the time that it's needed, by getting rid of a lot of the regulatory barriers, by being able to extend waivers, so that, if the environment in one area is not being changed dramatically, you don't have to have 3 or 4 different agencies come in and do an environmental review. Those are the kinds of things that previously have kept people from being able to get the money. So, we're getting the money out. And also, we now have a CFO at HUD for the first time in many years. And putting in the financial controls, everything from furniture to to disaster relief, so that we take care, we really protect the taxpayers' money, and it makes all the difference in the world. So we've also been talking to FEMA, to SBA, to all the agencies involved, and continue to do that on a regular basis. What can we learn each time so that we can make sure that we're much more efficient? But the thing that has really sped things up this time has been getting rid of a lot of the regulatory barriers that have been stacked one on top of another. And I think they were all put there for good reasons. But when new ones come along, they were supposed to replace the other ones, not add to them. And that's what's caused a lot of the backlog.
So you have some optimism that next time we are surprised by one of these predictable events, we're going to be in better shape.
It's going to be even better, guaranteed.
I'm going to turn to these questions, and I think there's some others. We probably have about another 10 minutes with the Secretary, so that's a chance for probably 4 or 5 of these. One of the issues, and I wanted to mention, is that Secretary Cisneros, who works with us here, was here yesterday and asked me to relate publicly how enthusiastic he is for the conversations he's had with you.
Yes, we've had.
One of his key issues has been this question of aging in place. We as a society have a tremendous number of people who are now aging, who want to stay in their homes, and who find that their own homes are no longer safe places for them. Our belief is that there could be investments that would save the society a lot of money and increase the dignity of people to stay in their homes, but we don't have a very good system of having HUD and HHS figure out where that money comes from. Can Medicaid resources be used to build ramps and bars in people's homes and bathrooms? And do you see aging in place as a priority for HUD, and what could you be doing to help us understand that?
It is very much a priority on several different levels. As you probably know, we've made some pretty substantial changes to the reverse mortgage program, which allows people to age in place. Again, the way it was originally structured, it really didn't take into account, surviving spouses and longevity that we're seeing in our society. So that's been fixed, and we continue to work on that. But in terms of aging in place and retrofitting houses, the reason that's so important is because each year we spend about $66 billion with a B dollars on elderly people who fall because these things are not done. And quite frankly, we could spend a lot less than that retrofitting the houses. So those conversations are being had right now. People are at least starting to recognize that this is an issue, and if we deal with it, in advance, it's going to cost us a lot less and save a lot of grief for these elderly people.
A question from an enthusiastic budgeteer says, wow, those Envision centers sound great. Where's the money coming from? Is it new money, or is it taking money away from existing programs?
I am so glad you asked that question. The money is already there. What we're doing is coordinating the resources at the local level. This is not a federal government program. We're helping to coordinate it and organize it. But it was intentionally designed not as a government program because we want those resources to be owned and the responsibility to lie with the local community. And that way, when the administration changes, the Envision Center doesn't go away.
Mm-hmm. Question about mental health and homelessness. I think and I'll elaborate on this a little bit because it's something we are focused and care a lot about. 50 years ago, then Governor Reagan basically deinstitutionalized California for a lot of very good reasons. 50 years later, the dominant issue in the mayor's race in San Francisco is whether they essentially reinstitutionalize. There is a sense that about half of the people who are homeless are either mentally challenged or have some kind of substance abuse issue, and we are either leaving them on the streets or institutionalizing them in prison. And that, challenging as it is, the idea of creating new state-based facilities where you essentially commit people to residence is now back in the discussion. Really hard concepts to get your head around. But how do you see the chronic homelessness problem that is exploding in a lot of cities, and do you think this is a reasonable response?
Well, it's not an either-or situation. But the fact of the matter is, it was probably done the wrong way when we just dumped, thousands of mentally ill people out on the street and said you're on your own. That's not reasonable. But there are a lot of the homelessness programs right now that deal with the mentally ill quite effectively. It's a matter of being able to gain their trust and have the appropriate types of medical professionals available to them to give them the support that they need to be able to exist in a free society outside and to protect themselves and to protect others. But it's being done. There are many programs that are very successful. We need to model on those ones. And we do also need to just take a reality pill and realize there are some people who really shouldn't be out on the street. And, we still have a responsibility to take care of them in a compassionate way, but we also have to be compassionate to the other people in our society and recognize that there are people who shouldn't be out there.
Secretary, your staff has compassionately told me that you have a day job I have to let you return to. So I have a final question, and this is really more as a member of the cabinet and someone who I know is very close with the president. What is the likelihood that Monday would be named a national holiday so that we could go to the CAPS parade? Or at least a flexible, could you take back, is there some kind of flexible work?
Well, I am so glad that the CAPS won because, it brings...
We needed something, this city, didn't we?
It brings, it makes me remember Detroit back in 1967 and the Detroit riots that really tore that place apart. And it tore relationships between people apart. The very next year, the Detroit Tigers won the World Series after 37 years. And that the unity that it brought to the city was amazing. And, we need to start thinking about the things that bring us together. And I think we can work out the things that divide us.
Well, we are all CAPS, and we are all Americans, and we are all thankful that you joined us today. We are going to do a quick switch here on stage and have our next panel come join us. So just bear with us for a moment.
Okay, great, yeah, perfect. Great. Well, that was a terrific discussion with Secretary Carson and BPC President Jason Grimay. We want to move to our second panel now. We're very pleased to continue this conversation with three experts in healthcare as well as housing. I think there was a link up there to the full bios of our second panel, but I want to just very, very briefly introduce them. We have Eileen Fitzgerald here, who is the President and CEO of Stewards of Affordable Housing for the Future, or SAFE. Ms. Fitzgerald has over 25 years of experience in housing and community development, and previously served as CEO and COO of NeighborWorks America. Next to Eileen, we have Dr. Don Molds, who is Executive Vice President for Programs at the Commonwealth Fund. Prior to joining the fund, Dr. Molds was Acting Assistant Secretary for Planning and Evaluation at Health and Human Services, where he served as Principal Policy Advisor to Secretary Kathleen Sebelius. And next to Don, we have Dr. Samuel Ross, who is the Chief Executive Officer for Bon Secours Baltimore Health System and is the market leader for Bon Secours Kentucky Health System. Dr. Ross previously worked at Parkland Health and Hospital System, Dallas, Texas, where he served as Executive Vice President and Chief Medical Officer. Eileen, Don, and Sam, welcome to the Bipartisan Policy Center. Thanks so much for being here. And maybe I might start actually with Don. Don and I work together at Health and Human Services, and Don.
Interest of disclosure.
What's that?
I said in the interest of disclosure.
Yes, yeah, in the interest of disclosure, that's right. And Don also served on the advisory group for BPC's most recent paper, which you have in front of you. And Don, I mean, you were there at Health and Human Services. One of the important recommendations, I think, in BPC's report is that the secretaries, we just heard Secretary Carson, the HUD and HHS ought to be meeting on a regular basis, designating departmental liaisons or offices with adequate resources to ensure there's departmental collaboration. I mean, you were there at HHS. You know, how does this work? How should this work? How important is this? And what advice do you have for this partnership between HUD and HHS in the current administration?
Sure. Well, first, thanks for having me. I'm honored and thrilled to be here, and it's a great conversation leading up to this one. So I was the lead at HHS on what turned into a formal collaboration between the two agencies, and involved from time to time the Department of Education as well. It came out of a famous lunch between my boss, Secretary Sebelius, and Secretary Donovan at HUD, and they got together, came to the same conclusion that I think secretaries before them have come to, and it sounds like Secretary Carson has come to, which is there's a lot of good that can be done between the two agencies. So there's just a lot of overlap with the mission, and the BPC report, I think, does a really terrific job of articulating a lot of those key issues. There was a person on the HUD side at a high political level who was designated as the lead there. We had a conversation every week. We met in person a good amount. When we couldn't meet in person, we had a call. We did that the entire time I was at HHS, which was sort of a remarkable thing. And we convened work groups among the career folks who were working on the issues that we were trying to tackle. And I think really meeting at all of those levels is critical. The other thing I will say that was, so of all the things that we did, I think the most meaningful was that we got out and we visited some of the folks on the ground who are doing the work, supporting the populations that were part of our mission, and that was really powerful. So I remember vividly going to Seattle with Fred Karnas, who was my counterpart at the time at HUD, visiting a supportive housing non-governmental agency, a community agency, doing incredibly meaningful work, essentially housing formerly chronically homeless individuals, so individuals who spent most of any given year on the streets, who had high incidence of severe mental illness, schizophrenia, bipolar disorder, addiction, and we're housing them at close to perfect rate. So almost everybody that they were bringing in, they had housed successfully for over a year. So they had almost no attrition. The substance use issues went down. Medication adherence was very high. Their intersection with emergency rooms went down. They weren't spending a lot of time in institutions like jails or prisons anymore. So really powerful. And the first thing that we heard when we visited them was, we have somebody on staff, we have a number of people on staff and spend about 30 cents on the dollar. The dollar's coming in by way of grants from your two agencies, writing for your two agencies because you don't coordinate. And so there are really important things that you need to hear. And the problems that you need to work on, I think, come alive when you go out and meet the people in the field doing the work. So, those are some of the things that I have to say, we made some progress. I was disappointed in the amount of progress we made. I think if I had to hazard a guess, there is still a conversation about what you can and can't do through regulatorily to merge HHS and HUD data. There are questions about single grant applications, which you would think is something that you might be able to do with the snap of a finger. But it all starts with conversations.
It's great. Very helpful insights, both process steps and on the ground. And Eileen, your members are on the ground. Your reach is pretty impressive. Members own over 130,000 affordable rental homes across the country. To what extent have your members bought into utilizing housing as a platform for health, and what are some of the innovative examples around the country where your members are really buying into health and wellness?
So, I wanted to just mention that before we even get to housing as a platform, there's just housing as health. And I think it's just incredibly important to realize that. And Secretary Carson talked about prevention. I mean, we know that the biggest prevention is to increase the supply of quality, affordable rental housing. We just don't have, at multiple levels, local, state, and federal, the will to get there. But that is going to be the most impactful thing we can do.
Housing is health.
Right? Housing is health, right. But using housing as a platform, I think there's kind of three ways that we think about that. One is increasing access to health care, and that might be insurance, transportation, bringing health care on site. A second is, how are we of value to the healthcare system, which is things like reducing ER visits, hospital readmissions. And the third is really addressing the social determinants of health. So in addition to housing, which is obviously the most important social determinant of health, such as food insecurity, education, employment, financial stability, community safety, and social cohesion. So we see housing as a platform doing all three of those. I think the first two are often the things that are focused on in health, and we think that that third piece of social determinants of health, if we're thinking about 2048, that's what really matters, because that's about not creating a pipeline of people with chronic diseases, right? But the challenges in a budgetary environment, a society where we think such short term, we often underinvest in that piece. But a few examples, Volunteers of America and Mercy Housing, who are two of our leaders in how they think about health and housing, have worked with Colorado Access to bring a care coordinator on site. It's being paid for by Colorado Access, and that's to work with residents to really make sure that they are accessing the healthcare system, have a healthcare team, and then bringing some education and services about improving health on site. And that the big kind of push and innovative push there was that Colorado Access is paying for it. Now that took about 2.5 years to just get that conversation finished, to get a pilot going. So it's a great example, but there's a ton of time invested in that. We just talked about homelessness. Many of our members run supportive housing, and obviously that's one of kind of the clearest examples of how you combine housing and health, and how you can, with good case management and good services, really reduce ER visits, readmissions, and most importantly, significantly improve the quality of life for the residents. In senior properties, this is a huge potential and one that I was really excited to see some things highlighted in the report. But the first piece is just increasing access. So National Church Residences has a place in a property in Pittsburgh, I think, that they were able to actually bring an on-site medical facility on the property. But there is, numerous examples of making sure that residents have access. Sometimes that's as simple as how do they get there? How, what's the transportation options there? And there's some really interesting things what's happening with Uber and Lyft related to that. Other times, it might be in a place. I remember being at a property where the residents could not access a podiatrist. That's a huge thing for a lot of seniors, right? And being able to bring that. So it's sometimes kind of as straightforward as that. A few of the SAFE members are participating in the I Wish pilot. And I know there's a couple folks from Leading Age. I wanted to call them out, and the Lewin Group for the great work they did on really creating the momentum for this pilot, which combines a wellness nurse. And I know that some just really initial responses and anecdotal reports have been that there's significant improvement in the outcomes of those seniors. And again, most importantly, they're aging in place and they are not using nursing home beds. So that is saving all of us a lot of money. So we look forward to more of that report. And we also have a couple of examples for families. Again, we see this less, but the community builders worked with Rush Hospital in Chicago to bring a nurse practitioner community clinic on site of a very large property where folks, they knew they were having a lot of issues of children and families accessing health care. And this can be as simple as, vaccinations and going to a much higher level. Mercy Housing piloted telemedicine in Atlanta for families. And this one, I think, is something that folks don't think about. You're thinking about telemedicine in a rural context or in a very isolated community. But, families who are working hourly jobs in this crazy economy we have where they don't even have set schedules, when they have to take their kid to a doctor, that often means missing work and sometimes getting fired. So they're at that choice between taking their kid to the doctor and that. So how we improve that access, how we break down those barriers in healthcare, that telemedicine project was looking at that. But that social determinant of health piece, one simple example is food security. How we can spend hours and hours talking about health and not think about the fact that we know that so many people don't have healthy food, nutritious food, or just get what they need per day. So our resident services folks have just reported that is probably the thing they worry about the most. And mind you, these are residents who are living in subsidized housing. So they're not maybe having as many issues about this as folks, down the block or not. But in that case, some members like Mercy Housing tried to actually bring an on-site food pantry to as many properties as possible. Others, obviously, things like Meals on Wheels. Community gardens can be great when they're really actively managed, but it also can be working with the neighborhood to really think about how to attract healthy food. And as we see a lot of redevelopment and some of the RAD redevelopment, some of the choice neighborhoods work, what we want is to bring that food to the neighborhood. So those are just a few examples.
That's great. Sam, I want to bring you into this discussion. Healthcare has a role here, and you all at Bon Secours are making a tremendous impact when it comes to community development. You're taking community benefit very, very seriously. When people ask you the question, why is a healthcare system investing in affordable housing, what answer do you give them? Can you talk about what the system is doing there and why they're doing it, and if you have any results to demonstrate that these investments are improving some of the metrics that we want to see, whether it's better health outcomes or reductions in preventable healthcare costs? All
right, thank you, and thanks for the invitation to be here. And for the next 20 minutes, I will be explaining this. Just kidding. So you referred to us earlier on as experts, and I would just flip that because I think what we all would acknowledge is that when we engage the community, then we understand who the real experts are. and that the solutions to a lot of things, whether it's HUD or HHS or others, are trying to address, really lie in our community engagement activities. So Bon Secours, has been in West Baltimore for over 135 years. When the sisters came from Paris with really what was the earliest form of visiting nurses, because they went into the homes and they did what was necessary to care not just for the patient, but also the family members. And so they've continued to do that as part of their charism of healing, compassion, and liberation. And then our mission is about good help to those in need, especially the poor and the dying. And that's been carried out not just for the hospital, because the hospital was established 40 years after the sisters arrived in West Baltimore, but they've continued to say, what is the need and what does the community identify as a need? So our why is really our mission. It's the following of Catholic social teaching, which is about the dignity, the respect that human beings deserve, the common good, and the justice. So that's been manifested by us in the fact that we are a 70-bed hospital facility in West Baltimore, but we have over 800 affordable housing units. So we flipped this already in the face of healthcare reform, and we've been doing this since the mid-90s. So if people want to see it in action, I invite everybody to come to West Baltimore. Don't believe what you see on TV and all that stuff. We'll get you in and out safely, not a problem. But our mission is the why for our investments. Necessity is why. And that necessity is about embracing our role as an anchor institution. And I think the opportunity that most healthcare systems have is to realize that we typically are the largest employer. We typically are the largest economic engine. We've looked at studies that show we contribute over $200 million annually to the city around investments and economic activities. And then the third, the mission, necessity, and the third is the community engagement piece. Because we got into housing, back in the mid-90s, because when people went out and talked to the community as to what their issues were, they didn't list high blood pressure, heart disease, diabetes, cancer as their priorities. The famous phrase in West Baltimore is that after community prioritization, the community said, our problem is rats and trash. And that phrase has persisted, to this day. And so we embrace that, and in healthcare, we often contact a person, an individual, and our question is, well, what's the matter with you in a healthcare sense? And in this world, in this environment, we got to flip that question to what matters to you. And in so asking it that way, that's where we got to the rats and trash, which led us to the reasons for the rats and trash were so many boarded up, vacant buildings that needed to be renovated. And so that was our entry into housing. And not because we wanted to be what we are as the largest developer in West Baltimore. We develop in partnership with Enterprise Foundation. We do most of it through low-income housing tax credits. But we're there because we are what we would call community responsive, which is caring for the health of the community beyond what most health systems see as a traditional approach.
That's great. Great. Thank you. And we'll come back to your advice for other healthcare leaders. Don, I want to come back to you now, being at Commonwealth Fund. What's the role of philanthropy here in more tightly connecting health and housing programs and informing policymakers about opportunities for collaboration?
Sure. So, I think when I think about answering that question, I think it's helpful to think about the space that government occupies and the space that philanthropy occupies. First big difference, and I say this with love and having spent most of my life in government service, government often is not quick to fund or to seize an opportunity, and philanthropy can be. So if there's something innovative on the ground that you want to look, that you want to seed and watch and study, you can do that very quickly in the philanthropic space. We spend a lot of time at the Commonwealth Fund right now thinking about health and housing and the possibility of health systems investing in housing as health solution. So, when I was at ASPE, we spent a lot of time looking at the case for housing as a health intervention. But the problem in government is that there have been, since I started working on this problem, at best, flat budgets on housing budgets, which means that if you're going to create a housing unit, you have to take it away from somebody else. So it may well be that you're going to save some money by taking a housing unit away from a poor family and giving it to a chronically ill veteran who lives on the streets. But you've done something bad to do something that is maybe marginally better, maybe not, right? So we've been spending a lot of time thinking about health systems that bear risk for the people that they serve, making these kinds of investments as a business decision. And that's the kind of thing that's very hard to explore on the governmental side. My view, for what it's worth, unsolicited, is that it's a second best solution. Anytime you medicalize something, you're not making it any cheaper, and there's a certain inefficiency to asking people whose jobs are to see 25 patients a day or however many to tackle some of these issues and learn more about them and to learn referral patterns and so forth. But it's certainly better than doing nothing about the problem. So we spend a lot of time these days thinking about that as well.
Great. Thank you. Eileen, I want to touch on one of the recommendations in the BPC's recent report, which talked about the need to integrate housing and behavioral health. We're in the midst of an opioid epidemic now. There are millions of Americans with severe or severely mentally ill. How do we integrate housing and behavioral health to provide a better platform for treatment as well as recovery? And have any of SAFE's members tried to tackle this and connect individuals who are residing in these properties, if they do have behavioral health conditions, to the services that they need?
Yeah, I mean, I was so excited that you guys were starting to surface this. And, obviously we have a bigger issue of just people not having access to mental health, insurance not covering mental health. So, that's way beyond my expertise, but I think that is a core problem. There is 3 quick examples, and these are kind of more at a base level. I think as we get to severe mental illness, the role is really just to make sure there's a place to refer to, right? So we need to make sure housers do what housers can do. But we have kind of 2 examples of interesting things in family properties, both actually in choice neighborhoods, where I think getting back to the rats and trash, it really is about listening, like what's the issue? And through different community conversations came up that people felt like there was not issues to any kind of mental health access, and that pushed our members to think about partnerships. In Chicago, in the Choice neighborhood in Woodlawn, POA, after some kind of rough starts, found a really great mental health provider, SGA, who has come in, and they have really done a lot of kind of what I would call peer groups, using other things like painting or woodworking or quilting or sewing or book clubs or whatever it might be, to actually create an environment to have behavioral health conversations. And their staff have facilitated those. They have seen, for the lots of folks who have participated in this, a reduction to only 3% of people being referred out when that referral rate was much higher. It also, because of the way they've done it, it's addressed some of the potential stigma issues that people in certain communities are saying, I don't need therapy, I don't need to do that. But it is getting to the underlying stress and trauma faced by people who live in poverty every single day and have grown up in poverty, and how do we do that? So we think that's really promising. Their big learning is you got to find the right partner. Mercy has worked with a school system in Sacramento, really interesting example, and brought a mental health navigator that is working with both the school system and the community. Again, in an area where stigma is really big and nobody wants to talk about mental health. This has been is probably more about reducing that stigma and facilitating access to the Sacramento mental health pieces, services, which wasn't happening before. So I think, the reflection to the opioid is how are you creating a culture in the place you live that says this is allowable, this is okay, and actually getting it above board. And then the other one in senior properties, this is something that obviously folks have dealt with for years and a whole different level, but one of our members in an HP Foundation, along with others, has been doing some work with AARP around Alexa. This was really started to just think, how do you do quick resident services connections? What they found is it's really having some impact on social isolation. So I think on the social isolation issues and how we think about those, again, we're touching the surface, but that is an underlying issue.
It's great. We had a forum actually yesterday morning with Senator Bill Frist and Tivity Health, the CEO. They were talking actually about social isolation, and this is not a touchy-feely concept. This is directly related to heart disease, stroke, dementia, as well as increased healthcare costs. So very important issues. Thank you for that. Maybe Sam, one last question, and I do want to open it up to the room. You talk to C-suite executives in the healthcare sector probably all the time, or more than any of us. What advice do you have for healthcare leaders, the CEOs of health systems, of payers, provider groups? How should they engage on housing-related issues? And do you think, I'm sort of leading on to this question because I do think this is the case, but how does this align with system-based, value-based healthcare transformation efforts? That's the talk of healthcare. We're taking baby steps, some would say, but as value-based healthcare transformation proceeds, how does this fit in, this sort of health housing integration?
Okay. And I do want to touch quickly on the second part of the first question you asked me was about data, because we get asked about that all the time. And we don't have a lot of longitudinal data, but we do know that by connecting our housing tenants to resources, that we do see those outcomes. So we know that behavioral health screening has already been mentioned at our housing facilities, helps us to identify folks who have housing needs. And we have a lot of outreach programs that allow us to connect like 85% of those people we see in an outreach setting within a couple of years in the program. We make sure we've addressed their housing insufficiency needs. So all of these things fit together and give us transactional data at this point in time, but we really are still trying to get to that transformational component. But to your current question about my colleagues, Secretary Carson, talked about how do we create hope, and as leaders, and particularly as CEOs and leaders of institutions, that's our role. I see my colleague Rosalind Brock out there. She's heard me say this. St. Augustine said, "Hope has two beautiful daughters, it's courage and anger." And it's anger at the way things are, and then courage to really do something about it. And so what I always challenge my colleagues and others to do is really adopt those principles, because we know that from a justice perspective, this isn't right. And so first of all, just acknowledge that there is a problem, and that as a leader of an anchor institution, that you have a responsibility and obligation to do more than just what's within your walls of that institution. And the second thing we remind people of, most of us in nonprofit settings have to do a community health needs assessment.
Yep. Every 3 years, yep.
And then we also have data that comes from our health departments, whether that's local health departments or state health departments, that tell us where our problems are, where our challenges are. And that also includes the community engagement piece as we follow through with that. And then the third thing I say is identify the partners, because we've been fortunate in how we've been able to do this with partnerships, whether it's been with, I mentioned Enterprise, the state housing departments, the city housing departments, and most recently with Kaiser Foundation, where we have an initiative called Future Baltimore in West Baltimore, where they've engaged with us and have long-term commitments to how we change health outcomes in West Baltimore. And then as it relates to the transformation piece, I can tell you over these years, what we've been able to show, particularly in West Baltimore, is by having these programs, housing and community engagement. We have a program called Community Works, as I heard the Secretary talk about an Envision Center. What we have is Envision Center for the last 20 years in West Baltimore. It's called Community Works. So if he or others want to come see that, again, we'll get you in safely and out safely. Come see that as an example of how those resources are brought to bear on the individuals that we also provide housing for. So we've been able to show that by having increased access to primary care, we're reducing those potentially avoidable utilization incidents, that we're reducing emergency department visits, that we're increasing access to behavioral health services and programs. And so it does tie to the incentives and the penalties that we all have in healthcare. And we've been able to demonstrate in West Baltimore that that has made a difference, particularly under our model in Maryland of global budget revenue.
Yep. Yeah, that's great. And Sam mentioned Kaiser as an excellent example. They recently announced a $200 million investment in affordable housing. Kaiser
Right.
Health System, one of the largest nonprofit health systems in the country.
We have already applied for some of those dollars.
All right, great. Well, let's just stop here, and maybe we'll open it up to the audience now. Very much interactive here, so if you have questions, please raise your hand. We have roaming mics. We'll get you a microphone. Please introduce yourself and ask your question. So looks like we have one in the front and one in the back. Yeah, that's great.
Good morning. Stacy Bridges with Veterans Vision. You said rats and garbage were the biggest problems in Baltimore. Is there anything that HUD is doing as far as purchasing these vacant places and fixing them up, and that would create jobs and training, more housing, and probably help with health care as well, because once people have a place to stay, they have security, and if security means less health problems. So are you guys teaming up with HUD and making sure that no one slips through those cracks?
We would love to do that. The interaction with HUD and a lot of other agencies really happens when we do a development, and it's primarily through, I mentioned, the low-income housing tax credits. That whole application process and then the whole development process brings in city and state and federal resources, and HUD is a component of that. But is HUD directly taking the lead on creating anything like that? And the answer is no. We've had some conversations, particularly because of the Envision Center concept that they've brought to West Baltimore, but early in its infancy and not a lot of traction at this point in time.
Yeah, and I would just say that, those are private, so the most important thing is to get more resources so that, mission-oriented developers, nonprofit or for-profit can do that. Or also for some of those homes, Ruth Ann Norton here is with Green and Healthy Homes. They've done a lot of work in Baltimore about those homes that can be saved and how to make those healthier places. But none of this it all requires. So HUD's role is to facilitate financing. We probably don't want HUD actually buying them up, but there's lots of partners on the ground who can do that good work.
Great. Question in the back? Yep.
Hi, I'm an intern this summer at the National Center for Health Research, but also a student at UC Berkeley, which means I've spent the past 3 years kind of living in Alameda County and Oakland, and I'm seeing a lot of the same issues in these areas that you guys have discussed, and you guys seem to be doing a lot of really great work. But one of the things I've noticed in Alameda County where there is a lot of similar programs is that we have an amazing bank of resources and that a lot of amazing work is being done, but there's still, the issues still continue to persist. And so I'm wondering, what can we do to make a more systemic change that actually impacts and creates long-lasting change that isn't reliant on just like nonprofits doing small-scale work?
So you're both the housing and the coordination. Yeah, so California last year passed a really kind of groundbreaking housing bill that's, and there'll be a housing bond, which you should encourage your friends and colleagues to vote for this fall. But it was tremendous. One of the big issues in California, as in many states, is actually kind of local zoning, land use, and permitting, and it's probably gone to a new level in California. So there is some pieces of that legislation that are trying to kind of break some of that down and fast track it. In the Bay Area, there's just huge density issues. And so there's a lot of, and there's this whole YIMBY effort starting the Bay Area of yes in my backyard as opposed to no in my backyard. But Berkeley and Oakland, folks don't necessarily want a lot more density. There's a challenge when you have a lot of people. There's accessory apartments issues. So there's a lot of interesting things, but much of it is both, getting some resources statewide and breaking down those local land use and zoning and permitting barriers.
It's also just a real shortage of affordable housing stock, and
Right.
so California is a great example that has done many things right in this space, but doesn't have sufficient affordable housing stock, and there's only so much you can do if you don't have it.
Right, so what's in those, the land use and the bond, is all trying to create
Right.
more stock.
And the other thing from a process issue I would add, because 20 plus years ago, what really helped in West Baltimore was a coalition that formed called Operation Reach Out Southwest. And these were 13 neighborhood associations. Bon Secours' role was really as the convener. And that's why the importance of the anchor institution is really highlighted. So now you fast forward to the current environment, and there's an organization now called Southwest Partnership. So it's extended beyond our first little area all the way down to the University of Maryland at Baltimore and other neighborhood associations. But in so doing, we brought more people into the discussion. So there are other foundations that are now involved in the discussions, along with city, along with the state. And the state has helped a lot with decreasing blight, because the governor allocated $75 million a couple of years ago to the city of Baltimore for the sole purpose of tearing down vacant buildings and doing deconstruction, with the idea that hopefully developers will come in and bring more affordable housing units in partnership with the city and the state.
There's also a very interesting regional effort to use the land around BART, which is controlled kind of more broadly in the Bay Area, to try to, more quickly increase stock.
Great. Question right here. Yeah, 2 questions. And then we have one over here. Yeah, so. Great.
Hi, my name is Jenna Shelton. I'm with BPC as well. And I was just wondering how you can balance supporting community development and also affordable housing without contributing to the issue of gentrification.
Wants to take that one?
Yeah, what is gentrification? It's such a fine line, right? I mean, we would say every person deserves to live in a vibrant community, and some elements of gentrification contribute to vibrancy. I think it is some longer-term planning, really thinking about how you preserve affordability. DC, for example, has TOPA, which is tenants' right of, to purchase. That's a good example of a kind of anti-gentrification strategy. Really investing kind of both local and state governments being strategic to make sure, as they start to see movement in communities, that they are investing in affordable housing, providing that financing, whether it's tax credits, but everyone has a different version, and obviously how you engage the community and tenant voice. But I think it's mostly thinking about preserving that income, and you have to do that upfront and thoughtfully.
And it gets to leadership and political will as well, because in Baltimore, there's 2 forms of community transformation that have taken place. One on the east side, around Johns Hopkins, that caused a lot of community consternation even before I arrived there, because the perception was you were displacing people in order to revitalize the community, as opposed to what we've primarily done on the west side is to do it with people in place. And so how do you get the entire community to elevate, to have that reinvestment into housing, redeveloping existing housing and new housing where it's appropriate? But it's a philosophy that, again, in West Baltimore is being driven by the Southwest Partnership and others to do it that way, as opposed to gentrification, in a broad way. But to her point, to Eileen's point, yeah, gentrification still occurs to a limited degree in West Baltimore, but it's really more of the doing it with people in place, the place-based strategy on that side.
Great. Question all the way in the back.
Great, thank you. J.R. Denson with the American Council for Energy Efficient Economy. Say that 3 times fast. I'm curious, particularly for Dr. Ross, Bon-Secours, you mentioned some housing rehabilitation and health outcomes of the folks who live in those houses and some data you're collecting around that. Is that data publicly available, and can you maybe speak a little bit about kind of what results you're seeing out of that work?
Right. There's not a lot that's publicly available because currently we're partnering with Morgan State University and one of their research arms to do that in more detail. We have a lot of, like I said, transactional data where we know how many people we've seen and what those specific interventions have. But we really want to get to the point that, after 2 years of being in our programs, where are you? Or 2 years of employment, have you moved out of home renting to home ownership and those kinds of things. So we still have a ways to go. We're really getting that kind of information.
Probably have time just for, we'll take these 2 as last questions. Yeah, so get some microphones in front. I think there's one question here and one question here, yeah.
Hello, Kayla Lumpkin with Quicken Loans. I'm a government relations intern. And I had a question primarily for Dr. Ross. I think there are a lot of similarities between the issues that Detroit and West Baltimore face in terms of eliminating blight and also development division between east and west side of the city. And I was wondering if you could go into more detail about the initial issues that the Community Works Center faced when it first started.
Yeah. What I mentioned, Community Works started over 20 years ago, and it grew out of the Operation Reach Out Southwest initiative. So what that organization did was actually create a 20-year plan for how they wanted to see revitalization and just to really say by 2018, West Baltimore would be a vibrant community. Now, we're in 2018 and didn't quite get there. But what has happened with Community Works, those programs and services that evolved there, which I said were similar to an Envision Center, grew out of that community input. So they said they wanted child care. So we have a child development center there. They said they wanted programs around teen pregnancy. So we have programs that engage those teen mothers. I went to a graduation just a couple of weeks ago. So they teach them not only parenting skills, but if they haven't finished high school, they have access to GED. Or if they have finished high school, we still encourage them to go on, to higher education. We have workforce development programs because, again, a lot of the 18 to 24-year-olds there don't have employment. We have the worst unemployment rates in West Baltimore. We have a reentry program there because the largest number of individuals in the Maryland correctional system come from our primary and secondary zip codes. So we have a program for men and for women that we go into the prison prior to their release, make those initial interactions, and the day they're released, we pick them up from the correctional facility and begin a 12-week program at Community Works to reintroduce them to society. Many don't have GED. We teach fatherhood initiative. We teach parenting skills, so on and so forth. So all of our programs there grew out of community engagement, and what the community said was essential to really making all boats, begin to rise in West Baltimore.
I think we'll do one last question. We're out of time, but just let's make it
last question.
quick.
I really appreciate it. I was wondering, what are you doing for the homeowners, the people who do actually own the properties that are vacant or in need of repair? How do they get access to, like, the National Housing Act, the same loans that Sean Hannity got access to fix up those buildings? How can they get access? How can the poor little widow get that help to, fix her bathroom or to update her house and so forth?
So, often those are, it would be different across the country. Sometimes local jurisdictions, cities or counties might be a lead on that. In some cases, it's nonprofit organizations who run those. And as I mentioned GHHI before. I think part of the challenge is if it's a loan, does somebody have money to repay it, right? Mm-hmm. So on the senior side, often you just can't there's just not enough money, so somebody needs a grant. And the kind of, we brought up the challenges of Medicaid before in, paying for some of these aging in place. So I think that's often, especially for seniors, is the big problem is that they can't afford a loan. There are some reverse mortgages. That is a very slippery slope that can be done well and responsibly and cannot be. And you really want to be careful. Some of the foreclosure stuff we saw with the crisis was seniors being scammed, trying to do an improvement to their house, their title getting taken. So it is an area where you really need trusted people who know what they're doing. But I would say it's mostly local.
It is. And in our instance, we've had dollars at times from the city housing department where you could do wheelchair ramps for folks who needed that improvement. Someone back there mentioned energy. So there's grants sometimes from the state for energy efficiency where you can do windows and doors. But typically, it has been grants for the most part, and typically it's not a whole lot of dollars. And then when the grants have run out, then the people don't have access to those resources.
Well, I want to thank all three of our terrific panelists for the discussion today. And I want to thank all of you for your excellent questions today, and everyone who's been watching online. Also want to just thank the Bipartisan Policy Center staff who put this event together. I also want to thank particularly Jake Varn and Andy Winkler, who are the key BPC project staff who co-authored this report, so thank you to them. We at BPC are going to continue these conversations. As I tell people here, that if you really want to improve health outcomes and reduce preventable healthcare costs in this country, you need to look outside the four walls of the clinical setting, and the home and housing is a perfect place to look. So thank you for your attention, and look forward to being in touch. Thank you, everybody.